Hello, now we are studying the opioid use disorder. A look at aberrant drug behavior, polysubstrate use, and psychiatric uh, comorbidity from Ontario Pharmacists Association. This is part one. A look at aberrant drug behaviors and polysubstance use. This is a faculty presenter disclosure. Dr. Boardman, the relationship with commercial interest. Creating research support does not apply. Speakers is borrowing divisor and C courses is OCFP. Consultant individual is OCFP, CMPA, Night Pharma, and this is me. I am Dr. Mahnaz Mehrabi. The objective is explore a differential diagnostic of aberrant behavior, identify other opioid and other substances that clients may be using while on MMT, describe the possible clinical presentation of clients using multiple substances, discuss potential treatment options for clients using multiple substances. Case example by Jane. A 50 years old woman known to your pharmacy for 6 months gets hydromorphone control release 12 milligram BID 60 per month, and hydromorphone IR 4 milligram TID PRN 90 per month, comes in 21 days after last visit and states she is out of pills. Okay, what should we do now? What should healthcare providers do when faced with a difficult clinical scenario? Differential diagnostic of problematic opioid use happens here. I don't know why we don't have a voice of the beautiful voice of the ladies here, but you should now listen to me, unfortunately. Dsmv, substance use and addictive disorders, mild 2 to 3 and moderate is 4 to 5, severe is 6 to 11, has to cause clinically significant impairment distress. This is the value we should give it. Cause to clinically insignificant something. Okay, this is a substance use and addictive disorder. Unsuccessful attempt to cut down. Long period spent obtaining drug or recovering. Neglecting other life activities. Use despite ongoing health consequence craving. Consequence of use. Repeated use in hazardous situation. Repeated use despite interpersonal harm. Tolerance withdrawal or use for longer than was intended. Okay, these are the situation of the patient and we should distinguish between these. What happens, I think. Additional definition, addiction is a primary chronic neurobiologic disease with genetic, psychological, and environmental factors influencing its development and manifestation. It is characterized by behaviors that include one or more of the following: impaired control over drug use, compulsive use, continued use despite harm, and craving. We have 4C: control over drug use, compulsive use, continued use despite harm, and craving. This is a behavioral include one or more of the following of the addiction. Okay, on the dopamine pathway, frontal cortex, and we have a serotonin pathway, and in this pathway on the VTA hippocampus we have a raphe ventriculus, we have a function, mood, memory, we have a processing, sleeping, cognition there, and it's written here nucleus accumbens. We have a function such reward, motivation, pleasure, euphoria, motor function, funning, compulsion, and preservation, such like this on it. Who diverts their opioids? Who diverts their opioids? Source where pain delivers were obtained from for most recent non-medical use NSDUH from friend or relative for free, from one doctor, or it's written here, bought from friend or relative, took from friend or relative without asking, bought from drug dealer or other strangers some other way, from more than one doctor, bought on internet. Okay, the most part, the 54% is from friend or relative free, but from more than one doctor is 0.3%. And the 80.1% is also is bought from friend or relative. Problematic opioid use, DDX, is what's going on at the opioid receptors. Opioid-induced hyperalgesia, OIH, or opioid-induced hyperalgesia, is paradoxical hyperalgesia resulting from long-term opioid therapy, LTOT. OIH is characterized by pain sensitivity, hyperalgesia, and allodynia in the absence of overt opioid withdrawal. It is distinct from tolerance in that pain extends beyond the area of initial complaint. Lowering the opioid dose may reset the pain threshold and may be a useful strategy. Lowering the opioid dose may reset the pain threshold and may be a useful strategy for opioid-induced hyperalgesia. What's going on at the opioid receptors? Opioid-induced hyperalgesia, opioid unresponsiveness is the answer. Term to try and avoid using in 2020. Other psychological issues. Personality disorders, chemical coping, And this is such a photo. Other psychological issues, for example, patient self-report, how to detect unauthorized substance use, how to detect it. Patient self-report, patient can report it, and we understand it, that this person, okay, use the substance. Observational, we smell the substance, we sight it, or we hearing. Okay, we can urine testing, point of care, immunoassay, or by the lab, by chromatography. We can detect unauthorized substance use. Concurrent substance use: tobacco, most common, cocaine, alcohol, benzodiazepine, opioids, and crystal meth. These are the concurrent substance use. Point of care for the urine test. Immunoassay usually tests for benzodiazepine, methadone, metabolite, opioid derived from natural source, cocaine metabolites, oxycodone or fentanyl if especially. Other psychological issue. Unforgiving drug. Okay, what's happened here? Unforgiving drug on a urine test is diazepam. Unforgiving drug on a urine test. That's a drug is unforgive on a urine test is diazepam. Case number 2 is a Bob. The Bob is 36 years old, heroin user with cocaine use, has been on methadone for 2 months, opioid free since starting methadone, still test positive for cocaine, claim to use a small amount on the weekends. Is Bob a candidate for take home? Take home dose generally are tied to clinical stability. Definition: a stable dose of methadone with allowance for occasional dose increases. No recent problematic drug or alcohol use. See table number 10. Compliance with treatment directive. Stable housing. Emotional stability. Emotional stability. What else? And good insight into carry safety issue. Okay, table number 10, problematic versus non-problematic drug use. What is the problematic drug use? Ongoing drug use with negative emotional, social, or financial consequences for the patient, unstable mood and relationship, unsafe or illegal activities. Non-problematic drug use is entertainment, sporadic drug use without significant adverse consequence, a stable mood and relationship, productive activity, work, family, schools. Case number 3 is Bill, 54 years old, past oxycodone IV user, history of an anxiety disorder, GP prescriber diazepam 20 milligram per day, been opioid free for 2 months on methadone program. Is Bill a candidate for take home? Guideline from CPSO retake home dose for patients prescribed benzodiazepine. G818, the physician prescribing methadone may give at least one take-home dose per week to clinically stable patients who are being prescribed benzodiazepine or opioid. May give at least one take-home dose per week to clinically stable patients who are being prescribed benzodiazepine or opioid. G819, the MMT physician may provide more than one take-home dose per week if the patient has medical or psychiatric diagnostic that warrants the use of the benzodiazepine or opioid, is a low to moderate therapeutic dose of the benzodiazepine or opioid, has not shown signs of benzodiazepine or opioid misuse or toxicity. Providers consent for the MMT physician to discuss their management with their opioid or benzodiazepine prescriber. Is prescribed and dispense the medication in a controlled dispensing fashion. Meets all other criteria for take-home dose eligibility. G820, the MMT prescriber should limit take-home dose of patients who refuse consent to communicate with their opioid or benzodiazepine prescriber. Case 4. Mary, 44 years old, recent transfer to your methadone program. Reporters of 2 year samples free of unauthorized substance. Level 6 take home. On first visit point of care testing positive methadone metabolite. Sent to lab for chromatography positive for fentanyl. What should we do? Does her dose of methadone matter? Acute intoxication contributes alcohol use. Acute intoxication contributes to methadone-induced sedation. Chronic alcohol consumption lowers methadone level through enzyme induction. CAGE questions. Have you ever felt you needed to cut down on your drinking? Have people annoyed you by criticizing your drinking? Have you ever felt guilty about drinking? Have you ever felt you needed a drink first thing in the morning, eye opener, to steady your nerves, to steady your nerves or to get rid of a hangover. Okay, this is a C, cut down of your drinking. Annoyed you, have people annoyed you, or have you ever feel guilty, or do you need when you eye opener? This is a CAGE. This is a cage question for the alcohol and drinking. Medication to reduce drinking. Naltrexone, competitive opioid antagonist, blocks alcohol-induced endorphin release, affects dopamine, decrease craving and relapse rates. The Sinclair method. Pharmacologic extinction. Take naltrexone 1 to 2 hours before drinking. Positive negative psychotherapy. The Sinclair method. Medication to reduce drinking is a naltrexone and Sinclair method. Naltrexone, take naltrexone 1 to 2 hours before drinking. Acamprosate modulate the glutamate. The neurotransmitter system centrally and is a glutamate antagonist. Relieves subacute withdrawal symptoms, not to be given until after acute alcohol withdrawal. Okay, acamprose modulate the glutamate neurotransmitter system centrally and is a glutamate antagonist. Relieve subacute withdrawal symptom, not to be given until after acute withdrawal syndrome, about 5 days after complete withdrawal syndrome. We should give it acamprose. Disulfiram, it's a aversion therapy. It's good for aversion therapy. And what is good for cocaine use? Use may decline with starting methadone. Treatment, consulting, no medication as of yet. Benzodiazepine use with methadone, high risk of overdose, maybe, and treat a slow taper with patient consent. May take years, may need admission if taking more than 50 milligram diazepam equivalent. May need admission if taking more than 50 milligram diazepam equivalent. Can detect behavioral summary of pharmacist role. Pharmacists should detect behavior change and physically see patient and interact on a daily basis. Education, adherence, if different doctor prescribing, can review drug interaction, can review safety of medication, and can find double doctoring. Resource is a OCP, Methadone Maintenance, a Pharmacist Guide to Treatment by CAMH, 3rd edition, titled Opioid Agonist Maintenance. Part 2, Psychiatric, Learning Objective, describe the clinical presentation of client who present with different psychiatric disorder, evaluate the potential drug interactions between psychotropic and methadone list a commonly used questionnaire and a screening tool for some psychiatric disorder, describe the roles of the pharmacist in providing care for these patients. Concurrent psychiatric disorders. Goals: to okay to establish a logistical approach to patient care for mental health patients on medically assisted treatment (MAT), to discuss and assess the underlying disease states of this subset of MAT patients, specifically mental health patients with concurrent psychotropic medication, antidepressants, anxiolytic, sedative, and antipsychotic, etc., to examine potential issues facing this group of MAT patients, for example, significant pharmacokinetic and pharmacodynamics interaction, to utilize practice-based tools suitable for this patient population. Methadone and concurrent disorder. Similar terminology in the literature. Co-occurring disorder, concurrent disorder, dual diagnostic, dual disorders. Case: Miss CL, 25 years old, female, methadone 100 mg full carries for 2 years. Recently more disruptive, talkative in the pharmacy. No other medication known to you. What are some possible reasons for her change in the behavior? More disruptive and talkative. For interaction model of concurrent mental health disorder: 1. Common factor model, 2. Secondary substance use model, and 3. Secondary mental health model. 4 is a bidirectional model. The same set of factors can contribute to increase risk of both substance use and mental health problems. Risk factors: biologic, social, environment. Okay, the common factors model is a mental health problems, biological factor, social factor, environmental factor. Secondary substance use model is a mental health problems, increase the change of developing a substance use disorder, self-medicate, for example, social anxiety disorder, self-treating with alcohol. Self-treating with alcohol. Secondary mental health model is a substance use may participate mental health problems. For example, cannabis may participate psychotic symptom. Number 4 is a bidirectional model. One problem increase the vulnerability to develop problems in other areas. Alcoholism can cause job loss, and job loss can cause depression. ADHD causes social school problems, can cause low self-esteem, and can cause drug use. Prevalence. The prevalence of psychiatric disorders is up to 10 times higher in the population on methadone maintenance than in the general population and is 2 to 3 times higher than found in community surveys of those with substance use disorders. Pathophysiology of addiction. The host is a biogenetic predisposition, sociocultural context, addic- addicting substance of or behavior, individual psychologic trip, and this is a dopamine. Common psychiatric disorders: depression, bipolar, anxiety disorder, personality disorder, borderline, and antisocial. Depression differential diagnostic Dsmv is a manic episodes with irritable mood or mixed episodes. Mood disorder due to another medical condition, substance medication induced depressive or bipolar disorders, ADHD, adjustment disorder with depressed mood, sadness. Depression and diagnostic criteria. Symptoms that occur nearly every day for 2 or more weeks. Depressed mood. Loss of loss of interest or pressure in most activities. Significant unintentional weight loss or weight gain. Sleeping difficulties, whether sleeping too much, too little, or frequent waking episode while while trying to sleep. Feeling of restlessness and agitation, fatigue or lack of energy, feeling of sluggishness, feeling of worthlessness or guilt, feeling of worry which may overlap with anxiety, problems thinking, concentrating, or making decisions, thoughts of death or suicide. Symptoms cause distress or impaired ability to function in daily life. These are the diagnostic criteria for depression. PHQ-9 screening tool is to assist the clinician in making the diagnostic of depression, to quantify depression symptoms and monitor severity, objectively determines severity of initial symptoms and also monitors symptoms change and treatment effects over time. Antidepressant and methadone. Increased methadone level. Many SSRI, fluvoxamine, potent potent uh, 3A4 inhibitor, fluoxetine, weak 3A4 inhibitor, potent 2D6 inhibitor, paroxetine, weak 3A4 inhibitors, and potent 2D6 inhibitors, sertraline, weak 2D6 inhibitors, and sertraline, weak 2D6 inhibitors, duloxetine 2D6 inhibitors, case reports of methadone toxicity. Decrease methadone level. by St. John's wort, 3A4 inducer, and risperidone. Importance of pharmacy and staff in relaying information to other healthcare. Is to other healthcare. Okay, increase serotonin in oxy, fluvoxamine, fluoxetine, paroxetine, sertraline, duloxetine can increase the methadone level, and risperidone decrease the methadone level. It means fluoxetine, fluvoxamine, paroxetine, sertraline, duloxetine can cause methadone toxicity. Okay, they are the cytochrome 3io4 enhancer. But risperidone decreased methadone level. Tricyclic antidepressant, QT interval prolongation, 84. Good choice in neuropathic pain. Use with caution, especially with high dose methadone. Greater risk in overdose compared to SSRI, especially in combination with methadone. Pharmacy can play a key role. Tricyclic antidepressant can cause the QT intervention. Good choice in neuropathic pain. Use with caution, especially with high dose methadone. Greater risk in overdose compared to SSRI. Bipolar. Bipolar 1 disorder, one manic episode with or without previous episodes of depression. Bipolar 2 disorders, at least one episodes of depression and at least one hypomanic episodes. Cyclothymia includes mood swing, but the high and lows are not as severe as those of full-blown bipolar disorder. Cythothymia includes mood swing, but the high and low are not as severe. Manic, diagnostic criteria. Okay, who is manic? Euphoria, extreme optimism, inflated self-esteem, poor judgment, rapid speech, racing thought, aggressive behavior, agitation, increased physical activity, risky behavior, spending spare, increased drive to perform or achieve goal, increased sexual drive, decreased need for help, tendency to be easily distracted, inability to concentrate, and drug abuse. These are the diagnostic criteria for manic. Mood disorder questionnaire. Mood disorder questionnaire. Mood disorder questionnaire. Has there ever been a period of time when you were not your usual self? You felt so good or so hyper than other people thought you were not you normal self, or you were so happy then you got into trouble. You were so irritable then that you shoot at people or started fights or argument? Oh, they are so small. Spending money got you or your family in a trouble? If you checked yes or more than one to above, have several of these ever happened during the same period of time? How much of the problem did any of these case you, like being able to work, having family, money, or legal troubles, getting into the argument or flight? Moderate problem, minor problem, severe problem. This is very hard. Patient self-assessment, a screening tool for a broad diagnostic of bipolar spectrum according to Dsmv criteria. 13 questions covering hypomania symptom, clustering symptom, and impaired functioning. Criteria for a diagnostic within the bipolar spectrum. More than equals 7 will be a positive question, plus is a clustering of symptoms, and plus is a moderate to severe symptoms. 9 out of 10 is a correctly identify specific, and 7 out of 10 is ruled out. Misdiagnostic of bipolar disorder. 60 is a depression, 26 is actually anxiety, 80 is a schizophrenia, 17 is a cluster B, and the A is alcohol. Antidepressant and bipolar disorder. The use of antidepressant for depression can lead to mania, and unmask bipolar illness can be very difficult to treat. Dsmv categories: anxiety disorder, separation anxiety disorder, selective mutism, specific phobia, social phobia, panic disorder, agoraphobia, and generalized anxiety disorder, obsessive compulsive disorder, ODB, body dysmorphic disorder, hoarding disorder, trichotillomania, and excortilation disorder. Trauma and stressor-related disorder, reactive attachment disorder, diminished social engagement disorder, PTSD, acute stress disorder, and adjustment disorder. Generalized anxiety disorder. Restlessness, feeling of being keyed up or no edge, feeling a lump in your throat, difficulty concentrating, fatigue, irritability, impotence, being easily distracted, muscle tension, trouble falling or staying asleep, excessive sweating, shortness of breath, stomachache, diarrhea, and headache. Social anxiety disorder, emotional and behavioral signs and symptoms. Intense fear of being situation in which you don't know people. Fear Fear of situation in which you may be judged, worrying about embarrassing or hum or humiliating yourself. Fear the others will notice that you look anxious. Anxiety that disrupts your daily routine, work, school, or other activities, avoiding doing things or speaking to people out of fear of embarrassment, avoiding situations where you might be the center of attention. Sociophobia Inventory, a brief self rating scale, 17 question rate from 0 to 4. Partisan social event scare me. A score more than 18 suggests a diagnostic of social anxiety disorder. Post traumatic stress disorder. Flashback or reliving the traumatic event for minutes or even days at a time. Shame or guilt. Upsetting dreams about the traumatic event. Trying to avoid thinking or talking about the traumatic event, feeling emotionally numb, irritability or anger, poor relationship, self destructive behavior, such as drinking too much, hopelessness about the future, trouble sleeping, memory problem, trouble concentrating, being easily started or uh, frightened, not enjoying activities you once enjoyed, hearing or seeing things that aren't there. Personality disorder. Cluster A or OD is a schizoid, paranoid, and schizotypal. Cluster B or impulsive, antisocial, narcissistic, histrionic, and borderline. Cluster C or anxious, compulsive, avoidant, and dependent. Prevalence of personality disorder in a methadone maintenance therapy population. 77% met criteria for at least one PD. Of those, 20% had a 2, 40% had 3. Presence of PD increased risk of relapse or failure to achieve abstinence. Cluster B is the most prevalent addictive personality, 69% lifetime prevalence of antisocial PD. Personality disorder, rigid and ongoing pattern of feeling, thinking, and behaving which often cause serious personal and social difficulties as well as general functional impairment. An enduring pattern of inner experience and behavior that deviate markedly from the expectation of the culture of the individual who exhibit it. American Psychological Association. Borderline personality disorder, originally thought of as on the border of psychosis and neurosis, rapid mood swings, see things in black and white, unable to maintain relationship, often misdiagnosed, self mutilation, usually have had multiple doctors. Borderline personality disorders. Communication skills, empathy versus sympathy. Maintain a strong professional relationship. Patient pharmacy agreement with some well defined boundaries. 25 years old female, methadone 100 mg, full carries 2 years. Recently, more disruptive talkative in pharmacy. No other medication known to you. What are some possible reasons for her change in behavioral? Possible cause of her change in behavior. Mania, SSRI to treat depression can activate mania episode, unauthorized drug abuse, cocaine, and borderline personality disorder. Summary of pharmacist rule: can detect behavioral change, education, adherence. If different doctors prescribing, can review drug interaction, can review safety of medication. Resources is the OCP and methadone maintenance by the Estor CAM.
Once again, here's some resources that are relevant for the time of this taping. It's always possible if you're watching this in the future, there'll be new resources, better resources. And I want to thank you very much for listening to this. I hope you found this valuable, and it was a pleasure to be able to give you this seminar. Thank you so much. Goodbye.